Hello, and thank you for joining today's webinar titled The Impact of Colonization and Infection for Vascular Devices. My name is Dr. Amy Barden, and I'm the Vice President for Clinical and Medical Affairs for the Vascular and Interventional Business Units, and I will moderate today's session. At Teleflex, our mission is to eliminate vascular-related complications and to save lives. Today, we will hear from Dr. Victor Rosenthal on the differences between colonization and infection and how various risk factors relate to catheter-associated bloodstream infections. At the end, we will also have a brief question and answer session. I would now like to introduce our speaker, Dr. Victor Rosenthal. So Dr. Victor Rosenthal is the medical director who specializes in internal medicine and infectious diseases. He holds a PhD in epidemiology and has 31 years of experience. His primary areas are focused on epidemiology and the prevention and control of healthcare-associated HAIs, patient safety, and the development of online platforms for global HAI surveillance. He is a research associate professor at the University of Miami Miller School of Medicine. He provides consultation on infection prevention, at Jackson Memorial Hospital, and is an advisor to medical students. He is also the founder and chief science officer of the International Nosocomial Infection Control Consortium, an organization solely dedicated to HAI research in low and middle income countries. Very proud of that work. He has led research efforts involving 2,500 healthcare workers. He has 393 scientific publications and book chapters, has been cited 18,000 times, and holds an H index of 63. And you can see some of this on your screen. Dr. Rosenthal has received recognition through 10 major interventional rewards for research and excellence. He serves as an editorial board member and a peer reviewer of over 100 scientific peer-reviewed journals, including The Lancet and others. Dr. Rosenthal is a paid consultant of Teleflex, and we appreciate you and your partnership here and your commitment to HAI reduction. And with that, I would like to turn the presentation over to Dr. Rosenthal.
Hello, good afternoon. Thank you for this invitation to share some research with you, and thank you for the people to attend in this seminar. I will share with you different topics. We will define colonization, we will discuss roots of colonization, we will review common organisms associated with colonization, we will discuss risk factors for CLABSI, central line associated bloodstream infection, and we will identify methods to reduce the risk of CLABSIs. Colonization is the presence of microorganisms at site or on body. Asymptomatic could be at the skin, mouth, intestines, airway, and invasive devices. I mean, it's the presence of microorganisms, but nothing happened. But infection is the invasion of host organisms and results from the interplay between the pathogens and the defenses of hosts they infect. But it's important to understand that colonization leads to infection. How we stop this? We have the famous chain of infection. We have the reservoir, that could be a person, could be an animal, could be a surface. Then we have the infectious agents, that could be bacteria, fungal, virus, parasites. And then we have the mode of transmission, that could be by direct contact, touching the person, or by droplets, short distance by the air, airborne long distance, like tuberculosis, by a vector like a mosquito, for like dengue, Zika, chikungunya, like a vehicle that could be the food. Then we have the susceptible host, that sometimes is a patient who is hospitalized and maybe is immunodepressed. Then we have the portals of entry, that the most important in this particular case are the invasive devices. Could be vascular devices, vascular catheters, Foley catheters, mechanical ventilators, and they are the portals of entry. And then the portal of exit is again the patient or the surface. we have colonized areas. Could be the skin, could be the mouth, could be the gastrointestinal tract, could be the airway, could be the invasive devices. And the body sites of colonization usually are specific to type of bacteria. For example, on the skin, we usually have mainly gram-positive bacteria, but we could have gram-negatives. But on the gastrointestinal tract, we usually have mainly gram-negative bacteria and anaerobic bacteria. This was published for the first time by Dennis George Mackey in 1977. You know, Dennis George Mackey is the one who, in 1974, published about the nationwide outbreak of BSI here in US. And then in 1978, he published the Mackey technique, the semi-quantitative technique. He developed this figure, and he found that the way of colonizing one vascular catheter could be by the hands of the medical people, the healthcare workers. For that reason, hand hygiene is key. Could be with the hub colonization. For that reason, it's important to disinfect the hubs. We will discuss this later. Skin microflora, that's why it's important, skin antisepsis and some particular kind of dressings, and could be subcutaneous tract and hematogenous seeding. In this picture, you see hubs without disinfection, with 5 seconds of scrubbing the hub, 10 seconds, 15 seconds. What you see here is that when you scrub the hub at least 15 seconds, you remove the colonization. That's why this is important. The picture of the left shows the external catheter surface with colonization, and the one of the right shows the intraluminal catheter surface with colonization. Why this is important? Because it is known, according to evidence, that during the first 5 days, the bloodstream infection are associated with external colonization, but after 5 days are more associated with internal colonization. That's why this is important. When you don't apply the right measures, the right interventions to prevent the colonization and the infection, you have colonization. After that, you have the formation of colonies of bacteria. Then after that, you have the biofilm. Then you have the thrombin, fibrin, sheath, and then you have the liberation of that to the blood. And then you have the bloodstream infection. There are many papers showing association of colonization with infection. We will share examples and percentage. This study was conducted in critical ill patients. 206 of them were colonized with Candida auris, and 37 of them developed candidemia, which is 18%. When they conducted multiple logistic regression analysis, they found that associated with candidemia were the use of central venous catheter, arterial catheter, total parenteral nutrition, previous surgical procedure, sepsis, previous use of antifungal agents, and chronic kidney disease. This study was conducted in neonatal ICU. Out of 1,017 neonates, almost 20% became bacteremic, 20%, with a drug-resistant gram-negative. Most frequently, they were Klebsiella, Enterobacter, Acinetobacter, and Pseudomonas. And they found that an independent risk factor for bacteremia was the presence of that drug colonizing the patient. Another example, this is a study conducted in a cancer unit. They found that of 75 colonized patients, 20% developed MDRO BSI with the same pathogen. Again, close to 20%, as in the previous studies. This study was conducted in neonatal and pediatric ICUs. To start, they found that the colonization of patients hospitalized at neonatal ICU was 2.6%, let's say 3%. And at the pediatric ICUs, 3.6%, both around 3%. But then after around 11 days, this study was conducted in Brazil. After 11 days, 39% of the colonized patients in PQ, pediatric ICU, developed systemic infection by carbapenem-resistant Klebsiella. And 18% of the patients colonized in NICU, neonatal ICU, developed systemic infection. And these systemic infections were, most of them, bloodstream infection, 63%, followed by pneumonia, 17%, followed by ventriculitis, 8%, followed by also intravenous infection, 8%, and UTI, 4%. With logistic regression, they identified that independent risk factor for the systemic infection was being colonized with the same bacteria. Unfortunately, 17% of them died. One couple of examples of complicated bacteremia are endocarditis, metastatic infection, fever or positive blood culture after 2, 3, or 4 days after starting effective therapy, and has an implanted device. The treatment for infection by Candida is 2 weeks. With any other microorganism, if the catheter removal is not possible, also 2 weeks. Enterococcus and coagulase negative staphylococci require 1 to 2 weeks. According to this study, conducted in pediatric ICU, the extra length of stay was 17 days. And according to this study, published by Patricia Stone in 2009, maybe you remember her because she is currently the chief editor of American Journal of Infection Control. She published this study in 2009, and he found that the average cost per patient, the extra cost per patient with BSI is more than $36,000 per patient with BSI. The mortality associated with Staphylococcus aureus with a follow-up of 4 weeks was 19%. Associated with Enterococcus, especially VRE, vancomycin-resistant Enterococcus, was 36%, the mortality rate. Associated with Klebsiella, with a follow-up of 4 weeks, the mortality rate was 81%. The mortality associated with E. coli infection after 2 weeks was 23%, after 1 month, 31%, and after 1 year, 55%. The mortality associated with Pseudomonas infection after 5 days was 34%, and after 30 days, 52.7%. All these are different studies published by different people, published in different journals, all of them showing approximately the same. The mortality with different bacteria. The mortality associated with Enterobacter species after 1 month was 21%. With Acinetobacter, after 4 weeks of follow-up, 50%. And the mortality associated with infection with Candida albicans was 42%. All these examples were BSIs caused by these particular microorganisms. As you saw, mortality ranged from 20 to 80%. I am proud to share with you, we published this study 2 months ago, recently. We conducted this study during a period of 24 years. We take time to analyze data and to collect data. In 728 ICUs, in 41 countries of Asia, Africa, Eastern Europe, Latin America, and the Middle East. We collected data from 1998 to 2022. We collected data of 280,000 patients, 1.8 million patient days of hospitalization. The mean length of stay per patient was 6.5, very reasonable. 61% of them were men. The mean age was 52. The number of BSIs all these 280,000 patients acquired were 3,500. The proportion of insertion sites and type of catheter were as follows. 40% subclavian, 28% jugular, 21% arterial, 7% femoral, 4% hemodialysis, 1.4% PIC. The mean central line utilization ratio, device utilization ratio of central line was 0.64. Maybe you remember that the last report of this, published by CDC in 2015, the device utilization ratio was 0.5, 0.55. This was slightly higher, above. The total centralized days were close to 800,000. Most of them, 61%, were hospitalized in medical surgical ICUs, the remaining in other type of ICUs. Most of them, 42%, were hospitalized in private hospitals, followed by teaching hospital, 30%, followed by public hospital, 23%, followed by nonprofit, 4%. Most of them were hospitalized in upper middle income countries. Of these 40-something countries, 19 were upper middle. 29% were lower middle, and 17% were high income countries. Now, the results, because the goal of this study was to identify why people acquire BSI. We analyzed 16 variables. These are the results. The age and the gender were not associated. You see the p-value, which is below 0.05, but the confidence interval of the age is going from one side to the one to the other side, meaning that it's not associated even with this p-value. Surgical hospitalization compared with medical was associated with the risk of CLABSI. The length of stay increased the risk of CLABSI 3% per day of stay. The use of central line increased the risk of CLABSI 4% per day of central line use. Insertion sites associated with a higher risk were jugular and femoral. And the type of catheter that showed the lowest risk with a significant p-value was PIC. Tracheostomy was also associated with risk of CLABSI, of course, because it's close to the insertion site. ICUs with the highest risk were adult and pediatric oncology. Public hospitals showed higher risk than any other kind of hospital, and middle-income countries show higher risk than any other income, like high income. We also analyzed why the people die, risk factor for mortality, the role of BSI. In the same setting, from 1998 to 2022, over 24 years, in 786 ICUs, 287 hospitals, 147 cities, 37 countries, we conducted a study to analyze why people die. The number of patients enrolled in this study were 300,000 patients, hospitalized during 2.2 million patient days of hospitalization. The mortality rate was 15%, 61% of them were men, the mean age was 52, the average length of stay was 7 days. The number of catheter days, central line catheter days, were 1.5 million, mechanical ventilator days, 800,000, Foley catheter days, 1.5 million. The central line utilization ratio was 0.66, above CDC, as we discussed before, but mechanical ventilation utilization ratio was similar to CDC and HSN, 0.28, as well as Foley catheter utilization ratio. You know that this is the formula that you divide the device days above patient days, and then you have this number. And the number of CLABSIs during this period of 24 years were 6,000, number of pneumonia, 11,000, number of UTI, 4,000. %51 of them were hospitalized in upper middle income countries, 30% in lower middle, 16% in high income, and 3% in low income. 42% were private hospitals, 30% were teaching, 24 were public, and 4 were non-profit. Mortality rate at respiratory and adult oncology was 30% and more. The highest mortality rate in these ICUs were there, respiratory and adult oncology. And the lowest mortality rate was at coronary and pediatric oncology, around 6% instead of 31%. The logistic regression. The idea was to identify why people die. What we identify is that at the coronary ICU, we found the lowest risk of mortality. You know, when you have one odds ratio and the result is below 1, 0 point something, is because this is protective. That's why if the odds ratio of coronary is 0.34, it is because the mortality there is low. But if you see at the end of ICUs, you see adult oncology 1.79 is meaning that there the risk is higher because it's above 1. In this particular case, with no significant p-value. Again, the same situation, you see patient days, the odds ratio is 1.01, meaning that there is a risk there because it's above 1. And meaning that for each one patient day the patient is hospitalized, for each day increase the risk of mortality 1%, meaning that if the patient is hospitalized 100 days, most probably the patient will die. Female gender, unfortunately, was associated with higher risk compared with men. The age increased the risk of mortality 1% per year of age. One person with 60 years old compared with 70 years old, the one with 70 years old has 10% more chance to die than the one with 60. All these variables are almost impossible to change. We cannot change the ICU, we cannot change the gender, we cannot change the age, of course. But we have something that was identified as a significant risk factor for mortality, which is BSIs, VAP, and UTI. What can we do? We need to find ways to reduce BSIs, VAP, and UTI because these independent risk factors associated with mortality are potentially being reduced significantly. That's why we will review some methods. CDC say that people can be colonized with pathogen and not produce symptoms of an infection. Colonization. Pathogens, all of them also cause infections. We saw the chain of infection. People receiving medical treatment in healthcare facilities, hospitals, nursing homes, acquire HAIs. HAIs can be acquired after procedures like surgical procedure or after using devices like vascular catheter, Foley catheter, mechanical ventilators, and frequently these HAIs are caused by MDRO, multi-drug resistant organisms, difficult to treat. As you saw, for example, the mortality of gram-negatives was close to 80% in some cases. This is the issue. This is from CDC as well. Pathogen reduction is a strategy that decreases the number of microorganisms that might lead to infection. Decolonization is a type of pathogen reduction that eliminates decolonizing pathogens. The primary goal of decolonization is to remove pathogens on specific places like skin, mouth, respiratory tract, urinary tract, guts, that are the home of microbes community that are naturally there. When a healthcare facility, this is also from CDC, identifies certain multi-drug resistant pathogens within their facility, CDC recommends colonization screening, which is an infection prevention method using lab testing to identify patients who are colonized with MDROs. Checking patients who are at risk for colonization helps guide infection control people to prevent spread. Traditional therapeutics are bath with chlorhexidine, which is, as you know, one essential recommendation of the guidelines I will mention later. Antibiotic prophylaxis like neomycin, aminoglycosides, especially more useful for colon surgical procedure, nasal ointments such as mupirocin with the issue of bacterial resistance for mupirocin, povidone iodine, or alcohol. Smith also recommend decolonization. The guidelines of them are to provide recommendation for decolonizing regimens targeting MDRO gram-negative bacteria carriers. And following are two examples. Machuk et al. Found that a significant reduction in all-cause mortality was associated with decolonization after 6 months of follow-up, 25% against 54%, huge difference, huge mortality. The target microorganism was colistin resistant, carbapenem resistant Enterobacteriaceae, super strong bacteria. The intervention was gentamicin. Oren et al. Analyzed another study in another place. The target was carbapenem resistant Enterobacteriaceae. The intervention was gentamicin plus colistin, and they changed the mortality from 53% to 22% with a significant p-value. You know, we will go now to the guideline published by Nicolo Buetti and Leonard Mermel, plus other people. You may know Nicolo Boetti because he's the infection prevention guy at the Switzerland hospital, and Leonard Mermel is working at the Brown University. He was the author of many guidelines to prevent BSI. They are important experts in prevention of BSIs. They published the guideline of IDSA, Infectious Disease Society of America, APIC, Association for Professional Infection Control, and SHAE, Society for Care Epidemiology of America, with the support of CDC and Joint Commission in May 2022. And they incorporate recommendations as essential, recommendations, additional, not recommended, and unsolved. And of course, the hand hygiene is one essential. We conducted this study you see here in this slide in 25 years ago in Latin America. We increased the hand hygiene compliance from 23 to 74% significantly. And in parallel, we measured the rate of HAIs. As you can see in the table to the right, you see the term clinical sepsis. This was something that was available 25 years ago from CDC, one kind of BSI. Now we change, LCBI1, LCBI2, LCBI3. All this stuff is new. I mean, 15 years, but this is the original definition. And we reduced the HAI significantly. Meanwhile, we increase simultaneously the hand hygiene compliance. And speaking about hand hygiene, the first recommendation that was available regarding alcohol hand rub was published by Boyce from US in 2002. The guidelines were the HIPAA-SHAE APIC IDSA guidelines recommending to use alcohol hand rub. Then other authors continue analyzing the same. But the first one was in US CDC. Maximal barrier. The first communication about the effectiveness of maximal barrier was published by Isam Rad, one US doctor, in 1994, 30 years ago. He reduced the rate of CLABSI by maximal barrier use. The mask, the cap, the sterile gown, the sterile gloves, the drape, sterile drape surrounding the insertion site, and he reduced the infection. Then other authors published similar findings, like Leonard Mermel, once again, the same Mermel, and this author, Marsteller, he published in 2012 a similar study, and he found that without the maximal barrier, the rate of CLABSI per 1,000 line days was 4.4, and with the maximal barriers, 1.3 per 1,000 line days. Speaking about line days, these guidelines of SHAE, IDSA, and APIC, if you pay attention to the last pages of this guideline, they still recommend to use not only SIR, which is mandatory, to use also rate of CLABSI per 1,000 line days, which is the numerator, the number of BSIs, the denominator, the number of line days, and then you divide BSIs by line days, they multiply this by 1,000, and then you have the rate. It's important to remember this. What about skin antisepsis? Around 30 years ago, we started reading papers about povidone iodine for skin antisepsis, chlorhexidine for skin antisepsis before the insertion of the central line. And then, fortunately, in 2002, Chaya Kuna Pruk published this meta-analysis of 8 studies, and he finally defined and concluded that it's better to use chlorhexidine for skin antisepsis instead of povidone iodine, with an odds ratio of 0.49. Let's review what is odds ratio. If you have a risk ratio, relative risk or odds ratio below 1, 0 point something, is meaning that it is protecting. That's why 0.49, it is protecting. The chlorhexidine is protecting compared with povidone iodine. And if it's above 1, it is a risk factor. Site of insertion. In 2020, Pitiriga published this study. He analyzed colonization by insertion site and infection by insertion site. He found that subclavian colonization rate per 1,000 catheter days was 13, for internal jugular was 7, for femoral was 23. This is colonization. But for infection, he found that for subclavian is 5 per 1,000 catheter days, for jugular is 4, pretty close to subclavian, overlapping, and for femoral was 7, showing the highest rate of colonization and infection for femoral. That's why this is another essential practice. Try to avoid femoral. as much as possible. Bundles. You may remember in 2006, a critical care specialist called Peter Pronovost in 2006 published nice paper in New England Journal of Medicine. He conducted a study in Michigan in more than 100 hospitals, and they reduced the rate to 0, applying 5 interventions. Hand hygiene before insertion manipulation, maximal barrier during insertion, alcoholic chlorhexidine for skin antisepsis during insertion, avoid femoral site, and remove non-essential catheters. He applied all these together, and they reduced the rate. Then IHI considered this as a bundle, and they recommend to continue with this. A bundle is a structured way of improving the processes of care and patient outcomes. A small, straightforward set of evidence-based practices, usually 3 to 5, but could be more, that when performed collectively and together and reliable, they have been proven to improve patient outcomes. Meaning that if you apply any of these 5 alone, you will have some effect. But if you apply all together, you will have better effect. Chopra, maybe you know him, he's the chief editor of Annals of Internal Medicine. He published a meta-analysis at EG Journal, which is the Journal of the Shea, in 2013. It's a meta-analysis of 23 studies analyzing the risk of BSI by type of catheter. He found that PIC are associated with lower risk than any other kind of CVC. Again, relative risk 0.62, meaning that PIC is protective. 0.62 is low risk. And another tip, when you have a relative risk, you need to analyze, delete from the 1, meaning that this is 28% less infections. 0.62 means 28% less infections. What happened about protective catheter technologies? As I mentioned before, Bueti, Mermel, and other people published the guidelines of APIC, Shea, IDSA with the support of CDC and Joint Commission in May 2022. They, as I said, recommended essential practices, additional practices, not recommended to do, and unsold. These protective technology are part of additional recommendation. What is additional recommendation? It is when you have in your ICU a CLABSI rate above what you want, above what is expected, above the standard, high rate of CLABSI. Number 1. Number 2, a patient has previously CLABSI. We are discussing about protective catheter technologies. And for example, a patient with cancer, chemotherapy, neutropenia, extreme ages, neonatal patient, or a very old patient, burn unit, trauma unit. All of them are indications for this. And the one I like is the one of CLABSI rate is above the standard. This systematic review conducted by Wang and published in 2018 analyzed 23 studies, and he found significant difference comparing standard catheter and antimicrobial catheters, and the relative risk was 0.7. Compared with standard chlorhexidine silver sulfadiazine and antibiotic-coated catheter were associated respectively with lower number of CLABSIs. Odds radio was 0.6 and 0.5 respectively. 0.6 for the chlorhexidine silver sulfadiazine, and for the antibiotic 0.53. And lower incidence of catheter colonization. Odds radio 0.44 and 0.30. It is important to remember that those coated with antibiotics, especially minocycline, rifampicin, are more useful for gram-positive microorganisms, not fungal, more or less for gram-negatives, maybe less, but more. But on the other hand, chlorhexidine and silver are good for eliminate gram-positives, gram-negatives, and fungal infections and colonization. This other study, published by Chong in 2017 with 60 studies, he compared again standard with minocycline, rifampicin, the relative risk was 0.29, and for silver, the relative risk was 0.57 for bloodstream infection. But for colonization with miconazole, rifampicin, the relative risk was 0.14, which is a lot, and 5 fluorouracil, the relative risk was 0.34, and for chlorhexidine silver was 0.60. All of them significant. When we use ultrasound, two-dimensional ultrasound, we increase the chance of success at the first attempt by 57%. We decrease the time to success cannulation by 30 seconds. We reduce the rate of total complications by 71%. We reduce the chance of arterial puncture by 72%. We reduce the chance of hematoma by 73%. Based on this, ultrasound offers gains and safety and quality when compared with anatomical landmark. When I used to work in ICU, in 1989, a couple of years ago, we didn't have this methodology, and we used to have the anatomical landmark technique. And this recommendation is essential for the SHAE, APIC, and IDSA guidelines published last year in May 2022. What about the BAT? Another essential recommendation published by Alfonso in 2016. He analyzed all the studies and conducted the meta-analysis. The overall BSI reduction was with the odds ratio of 0.74. But the subgroup of CLABSI central line as the BSI, the odds ratio was 0.50, better than any other kind of BSIs. As you see, the odds ratio was 0.80. And this was more evident with gram-positive bacteria. 0.55 was the odds ratio. The suggestion is to use 2% chlorhexidine washcloth to prevent any kind of BSI and CLABSI, and especially useful for gram-positive bacteria. What about dressing with chlorhexidine? You know the famous two, the disc and the gel. And this meta-analysis combine all them and analyze the effectiveness of all them to reduce the risk of CLABSI, and the relative risk was 0.71, which you know is 29% less infections, no difference between this and gel. Long-term CBC, the CHG dressing decreased exercise even more by a relative risk of 0.37, which you know is a reduction of 63%. But the bad part of this is that they found contact dermatitis in neonatal and pediatric population. That's why it's recommended above 2 months of age. Oh, needleless connector, nice topic. According to the SHAE, APIC, and IDSA guideline published last May 2022, this is unsolved. Why this is unsolved? Why is that? Because when we switch from streptococcus to needleless connector, we found many outbreaks, I could say, many rises on the BSI rate. Why was that? Basically because there are 3 kinds of needleless connectors: positive displacement, negative displacement, neutral displacement. And they are different. And we need to pay attention to that. For example, the one with the biggest amount of reflux is negative displacement. And you can find this at the INS guidelines published in 2021. You can find this there. The moment of the reflux with the positive displacement is during connection. The moment of reflux of the negative is during disconnection, and the neutral has no reflux. That's why it's important to understand that if you are using a needleless connector with positive displacement, you need to disinfect, of course, then you need to flush, then you need to disconnect and then clamp. It's the opposite for negative displacement. Instead of disconnect and clamp, you need to clamp and then disconnect because of the moment of the reflux. Another important point we will discuss later in the next slide, which is scrubbing the hub. Oh, sorry. From 2012 to 2014, we conducted a randomized clinical trial, a very good study in India, in 2 cities of India. And we conducted this during 2 years. We published this in American Journal of Infection Control, 2015. The rate of those patients, randomized patients using streptococcus was 6, using needleless connector was 2. We conducted a cost effectiveness analysis, and for $1 we invested, we saved $124. Then we conducted a meta-analysis, and we found more or less the same, 60% reduction on the CLABSI rate. This study was conducted by Sylvia Munoz Price, who used to work here in Florida, where I am now, and now is working at Virginia Commonwealth with a good friend of mine who is Gonzalo Berman, who is also from Latin America, from Argentina, as I am. She published this years ago in 2012, and she applied scrubbing the hub with chlorhexidine plus daily bath with chlorhexidine, and in one unit, the rate of CLABSI was reduced from 8.6 to 0.5, huge reduction, 90% reduction. Another unit from 6.9 to 1.6, another unit 7.8 to 0.6. Very significant reduction. And this is the last slide before conclusions. Also essential practice and part of the IHI bundle, part of the INS, part of the Pronovos study, we need to remove catheters when they are not necessary. That's why we need to check every day the indication of the catheter, every day. As I mentioned before, we conducted a study to analyze risk factor for CLABSI. We analyzed 16 variables, and we found that each day of central line increased the risk of CLABSI by 4%. Meaning what? If we have the line 10 more days, the chance of BSI is 40%. If you have the line 20 more days, the chance of CLABSI is 80%. This is a study that demonstrates how important is to pay attention to the IHI bundle, to the study of Pronovos, to the guidelines of INS, to the guidelines of SHEA, APIC, and IDSM. Conclusions. Colonization is frequently a step before infection. As you saw, 20 to 40% of the colonized catheters lead to infection. Routes of colonization frequently are vascular devices. Decolonization is recommended by CDC and by ECMID. Treatment of infection requires 1 to 2 weeks. The extra length of stay because of BSI is 17 days, and the extra cost per each infection, CLABSI infection, is $36,000. The attributable mortality of gram-negative plastic infection ranges from 33 to 80%. You remember the slides. And the mortality by gram-positive infection ranges from 13 to 36. Central line days are a significant risk factor. You saw the previous slide, 4% per day. PEAK show the lowest risk for CLABSI. CLABSI is a significant risk factor for mortality. That's why preventing CLABSI, we can reduce the mortality. You saw our study showing that there are many variables associated with mortality, but no one of them can be modified except the infection. Technology has demonstrated evidence showing that there are many ways to reduce colonization and infections, and that colonization leads to infection. Thank you so much.
Thank you so much, Dr. Rosenthal. That was great, and the information was outstanding. You know, as I listened, I was reflecting on how many years the guidelines have been in place. For example, the bundle or max barrier recommendations. It's we're not talking about something new or new preventative. It's really more compliance to the strategies that are out there. So we have questions. So I'd like to start asking a few of those. Here's one from an infection preventionist. What do you suggest for infection preventionists that struggle with compliance to standard practices that are evidenced, such as utilization of max barrier, or actually doing the CHG bathing that has a high level of evidence? What would you recommend for that?
Okay, this question is also answered on the guidelines published by Boetti and Mermel in May 2022. They recommend measuring the compliance and providing feedback to the healthcare workers. And we have many, many good examples of that. I mean, measuring compliance, creating charts with the compliance, and provide feedback. For example, we can, speaking about HANA-Gene, for example, we can measure the HANA-Gene compliance and by profession, by sex, and then provide a feedback to the healthcare workers working at this unit, but not overall. Stratify by variables. For example, we found that the compliance of men in this ICU is, I don't know, 55%, and of women is 92%. If you say this to the doctors and to the men, or to the nurses, or to anyone, the men will feel very bad. And also, if you reply to them and you provide the percentage other than per man, per profession, compliance of doctor and women, the one with the lowest compliance, which usually is the doctor. I'm sorry for saying this, but it's usual. They will feel bad. We conducted a study during 13 years in 19 countries, and we published this in 2013 at the SHEA journal. And we improved the compliance from around 40 to around 86 in these 19 countries, 150,000 hygiene opportunities. And then we conducted logistic regression analysis to identify why people don't wash their hands or don't perform hygiene. And we identified that the worst were the men and the doctors. And the best were women and nurses. Sorry, long answer.
No, I think you have a point there. I think it's transparency and observation. Like when you can identify it and then acknowledge it, I think we do it different. Like the checklist and the CLIP guideline, et cetera, for when we do central line insertion, for example. So I have another question. This one comes from Autumn. So thanks, Autumn, for the question. Are there any big studies for BSI for PIVCs? So peripherally insert PIV catheters.
Okay, good. There are a couple, not a lot, but there are. Excellent question. There are studies from US, from Australia, from Italy, and they found that the rate of, I would say CLABSI, peripheral line as the BSI, I like to say CLABSI, is around 0.5 per 1,000 peripheral line days. You know that the last CDC NHSN report, instead of publishing SIR, publishing rate of CLABSIs per 1,000 line days, show that the rate of CLABSIs in US, according to CDC NHSN, is 0.8. But the CLABSI is 0.5. It's very close, very, very close, very close. Meaning that CLABSI is as important as CLABSI. But remember that the market of central lines is 10% of the vascular catheters of US, and around 90, 80 to 90% are peripheral lines, meaning that if the rate is almost similar, it's meaning that there are many more CLABSIs than CLABSIs, because the rate is close, but the use is 90% more. We conducted a study during 8 years, and we published it in 42 countries, again, because, we have been working during the last 31 years in low and middle income countries, more or less when I was born, this is a joke. And we found that the rate of CLABSI in this region was close to 5 per 1,000 central line days. But the rate of CLABSI was 2.5, meaning that in low-income countries, low and middle, which represent 67% of our planet, in this setting, the rate is half. But again, the market of the peripheral lines is 90% of the central, meaning that it's a huge issue any place, everywhere, in US and outside.
Yeah, that leads to another question. With the potential of PIV-related bloodstream infections being a reportable, is it as important, in your opinion, to maintain the same barrier precautions, to maybe potentially have a protected mechanism, protected device, if all of those also contribute to or seed another device that might be in place? If that reporting is going to come, what would you recommend for infection prevention teams and facilities to start looking out related to PIV infections?
Excellent question. If I would be Boetti or Mermin, I would say we need more data. We need data, but makes sense to apply significant interventions to reduce the risk of CLABSI, as well as we have been doing for CLABSI, because it's a similar problem, CLABSI compared with CLABSI. I would say that we need to start taking care of the peripheral line as much as the central line. more than we used to do, and we need many more studies to analyze the impact of each one of the interventions. But conclusion, CLABSI is a big problem, worldwide, not only US, worldwide. There are many evidence published about this.
Yep, yep. Here's another question. I know this is one of the guidelines, and the question is, in your experience, have you seen differences in rates of infection per number of lumens of the catheter? For example, a 1 lumen catheter versus a 3 lumen catheter.
Yes, 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 yes. The answer is yes. There are differences when the catheter has more lumens. Increase the risk because you have entrance of microorganisms, colonization, infection with more lumens compared with less lumens. And there are studies showing this, and we read these studies published by US authors, and there are also data published, available from the data outside US that we didn't publish yet, but we found that there is more risk of CLABSI in 3 lumens compared with 1 lumen. Yes, the answer is yes.
Thank you. And I think that is evidence in all the current guidelines too, to use the least amount of lumens for the therapy of the patient to reduce risk. And some studies, I think, say 17% per lumen. So it's very interesting how we device select. So here's another question. Celso, I hope I pronounced that right. So thank you for the question. Do you know why oncologists do daily blood cultures on specific patients, for example, leukemia? Do you place PICs in these patient populations with at least 2 negative cultures? And what is the rationale behind the daily blood culture? So that's a big question. So if you could address that, would be great.
Okay. Yeah, I understand. Yeah. Oncology patients have chemotherapy. Chemotherapy frequently leads to neutropenia. Neutropenia is less neutrophils on the blood. And the neutrophils are our defense against microorganisms. When the patient is neutropenic, they don't have any sign or symptom of infection except fever. There is a famous syndrome called neutropenic with fever. And this is one infectious disease emergency. I believe, I am not an oncologist, but I believe that they take cultures every day because they wish to identify the bloodstream infection before the symptoms, because as I said, neutropenic patients frequently have no symptoms. And I think they do for this. I disagree. I mean, I don't think it's necessary, but this is something beyond my spectrum, which is oncology. But I understand why they do that. In fact, when I went to my fellowship in 1989, in my first patient I took care was a patient with cancer and neutropenia. And for that, I started studying this particular syndrome during over the last 30 years.
Yep. Thank you for that. And I think some of these are very hospital specific, and sometimes going back and asking the why helps those teams too, and then utilizing the evidence to support. I have a question from Eduardo. So thank you, Eduardo, for the question. It says, is redness at the insertion site an infection?
Good question. This redness probably is a phlebitis for sure, because the way to rank the phlebitis from 1 to 5. And if the patient had redness, probably it is a phlebitis. If the phlebitis is an infection, is questionable. We need to analyze that situation. Could be a chemical reaction, could be infection. Most probably it's an infection. Most probably it's a bacterial phlebitis.
Yep. Thank you. Very good presentation. This is a comment. In your opinion, the evidence support the use of protected catheters in high-risk patient populations, for example, oncology, hematology, neutropenic transplant patients?
Yes. In fact, those together with the high CLABSI rate of the unit, or patients with recurrent infection and extreme age are exact indications for protective catheters. Yes, they are. And the evidence is high evidence about that for adult population, not for pediatric, but for adult population, the evidence is very high recommending this.
Thank you. In your opinion, is it important for the teams that are doing the surveillance and looking at new product technology, is it important for them to understand the bacteremia and the cause or the device associated, like the type, so that they can choose effective strategies to reduce risk when they still have a higher than normal reported infection rate?
Yes, it is important because if you use antibiotic-impregnated catheters like minocycline, rifampicin, they are more effective for gram-positive bacteria, but almost not for gram-negative, maybe some gram-negatives, but nothing for fungi. But silver and chlorhexidine, they are useful, extremely useful, very effective for gram-positives, gram-negatives, and fungi. That's why it's important to know the epidemiology of your ICU, of your setting, ICU or not ICU. You need to, I used to create pies with the name of the microorganism per site. For example, the pie of microorganisms of our BSIs, our pneumonias, our UTIs, our SSIs. And then this lead us to the intervention. Because if we know the epidemiology, for example, if, I don't know, more than 70% of our BSIs are Staphylococcus, of course, we can use minocycline rifampicin. But if more than 60% of our infections are due gram-negative or fungi, we cannot use antibiotic-impregnated catheters. We need to use or silver or chlorhexidine or together. It is important to pay attention to this.
Thank you. Thank you. Let's see. You mentioned many guidelines. You mentioned IDSA, SHEA, and APIC quite a bit. And there are several people on this session that probably also follow INS. So how is it important that we look at all of the guidelines to make sure we're fully caring and working to the best standard of care?
INS published the last guideline in 2021, the previous one in 2016. All of them are excellent. The last one has 230 pages. I read all of them. Of course, I cannot remember everything there because I am not a vascular access specialist, but they are very comprehensive. INS are beautiful, are perfect. I recommend you to pay attention to these guidelines. And you have some detail. For example, what I mentioned before regarding the needleless connector displacement system, positive, negative, and neutral, I found this in INS 2021. I didn't find this at the SHEA guideline. Oh, something interesting. I found at the INS guideline as well, which is not in the SHEA. For example, the drying time of alcohol you can find at INS guideline is 5 seconds, but the drying time of chlorhexidine is 20 seconds, and the drying time of povidone iodine is 6 minutes, meaning that for that reason, we should not use povidone iodine for scrubbing the hand for disinfection, but if we use alcohol, you know, SHEA guidelines say 5 seconds, which for me was strange because I had the concept of 20 seconds, but they published May 2022, 5 seconds. But if you go to the INS, 5 seconds is good for alcohol, but it's not good for chlorhexidine, and of course it's not good for povidone iodine. INS are perfect. You need to read them. Not you, all the people. You already know.
I do think that this is where there's a confusing factor, though, when we're trying to ensure that hospitals are utilizing protected technology, that they're using max barrier, that they're, you know, not routinely placing catheters, like some of these little variables between the guidelines, and it's almost putting all the guidelines together and just making sure your hospital policy is up to guideline. I think that's probably even a bigger opportunity there. I do have a couple more questions, so we're going to go over a few minutes if that's okay. Sheila asked have you seen a difference in accumulation of skin organisms with CHG bathing plus CHG scrub at PICC insertion sites opposed to just using a CHG scrub?
Long question. I don't know if I understood the question.
So a difference in accumulation of skin organisms with CHG bathing plus CHG scrub at the PIC insertion site opposed to just CHG scrub at PIC insertion. This might
Oh,
have,
yeah.
yeah,
Now I understood. Okay, yes, it's better to scrub the hub plus bathing, both together. Yes,
yeah.
both are essential practices. Yes, the answer is yes. You need to apply both. This is the answer. Sorry, I didn't understand, but now I
No, it's
understand.
okay. It was a long one, so apologies. Another question from Jessica. Thank you, Jessica, for the question. Does the frequency of breaking the skin barrier, for example, with multiple short PIVs, have a more increased risk of BSI versus just putting in a central venous catheter?
Oh, excellent question. Excellent question. I am not aware if any study analyzed this particular situation, but the rationale is that if you don't have good access using a peripheral line, the choice always is a central line. I am not aware of a study analyzing exactly this particular question. And I didn't see this in SHEA guidelines or INS, this particular one. But of course, if you don't have a good access for peripheral line, maybe the best option is midline, which is also a peripheral line, but different length, or maybe a peak. Yeah, it's better to do not attempt many times to insert the peripheral line.
Yeah, I think it's interesting. You know, when we're trying to insert maybe a peripheral line, many different people are trying, and then all of a sudden, you know, we have a specialty team that may be available to come, and then if not that, the PIC team, and then it's really, I think to address that even more is how many times is the patient being stuck overall? Because remember, we by INS guidelines, it's 2 times by 2 people in a day. But we go way over that. And sometimes it's the patient's the only one that tells us how many times. So choosing the right device for the right patient at the right time, I think really minimizes risk. So
I agree.
Okay, let's see if I can find one more question for us. This is from Debbie. So Debbie, thank you for the question. Has there been studies showing any differences in colonization rates from different catheters, materials, or technologies?
Good question. Yes, there is. Yes. The protective catheters show less colonization and less infection, yes. And they could be with chlorhexidine, they could be with povidone iodide, chlorhexidine, silver, antibiotics like minocycline, rifampicin. Yes, there are differences.
Great, thank you for that. All right, there are lots of questions, and I'm going to take one more, and then we'll wrap this up. And this is from Amy. Okay. How do we get inserters to not hub the vascular access device and suture so tightly that the nurse cannot clean under the hub and the insertion site?
Can you repeat this?
Yes. How do we get inserters to not hub the line and suture it so tightly that it can't be cleaned under the hub and the insertion site?
To avoid the suture to be too tight?
Yes.
Good question. This is more for you than for me. You are a vascular access expert.
So I guess my question, let me reframe the question. Should we be using suture?
No. I mean,
so can you elaborate why? Like, why shouldn't we be using suture? I mean, some facilities have moved away from it, but from an infection prevention point of view, should we be utilizing suture to secure devices today?
Okay, going back to IDSA, SHEA, and EPIC guidelines, this is an unsolved issue. It's not clear. They publish essential, additional, not recommended, like, for example, antibiotic prophylaxis, systemic antibiotic, it's not recommended. Or changing with fixed interval, not recommended. This one, suture, is unsolved. For that reason, I pass this question to you, because you are an expert. You have experience with this. I don't, because I never suture the device. And according to the infection control guidelines I read, this is an unsolved issue, meaning that I don't have the perfect answer for this yet. Maybe in the future, in the next SHAE guideline, but not yet. Now it's unsolved.
Yeah, I think, you know what, to all the learners, you know, we had over 300 people on today's call. I feel like you mentioned a couple gaps that some great researcher could take a look at and help us, you know, even protect patients more through patient safety. So with that, I want to thank you again. This was fabulous, and I really just appreciate all your wealth of knowledge, but also your dedication to infection prevention and to making sure that patients always receive safe care. If you'd like to learn more about the information shared on today's webinar, you can click on Talk to My Rep button on the bottom of the screen. You can, it'll send you an email to your local Teleflex rep, and then they'll reach out to you if you want to discuss anything. Don't forget to download all your additional resources. There's lots of materials that you have access to there. Once you leave the webinar today, you'll receive a short survey on the presentation, and we would love your feedback. We would just appreciate understanding if you appreciated the content and then future content that you might want to see. We would also, you'll also receive a follow-up email with any directions on how to get the link to your contact hour, et cetera, through Teleflex Academy. So thank you very much, and thank you for attending today's webinar on the impact of colonization and infection for vascular devices by Dr. Rosenthal. And again, on behalf of all of Teleflex, Dr. Rosenthal, I really appreciate you and your time and your expertise on this topic today. So thank you.
Thank you for the invitation. Thank you for attending. And at the last slide, the slide with thank you, you have my webpage, and you can download from there all our papers available there. And also you have my email address there if you have any question, any comment to make. Thank you for the invitation. It was a pleasure sharing this moment with you. And all the questions were excellent, wonderful, awesome. And they challenged us to, as you said, to research more. Thank you so much.
Thank you.